When you look at a portable chest x-ray, how do you know if the inspiration is actually good enough to trust that you're seeing everything? Or another question might be, are the lung fields noticeable enough to find the problem in this patient? In this video on chest x-ray interpretation, I'll show you a simple step-by-step way to tell if the chest x-ray inspiration is adequate so you don't mistake poor inspiratory effort for pneumonia, pulmonary edema, or cardiomegaly. Hey guys, I'm Dr. Busti and welcome to another topic review at This Is Why, a show that helps healthcare professionals transform their medical knowledge from not only just knowing the facts, but understanding the why in what we do every day in clinical practice. All right, guys, let's get started. All right, so our first question is in this medical education lecture is why should you learn how to determine if there's adequate inspiration on a portable anterior posterior, or AP, chest x-ray? Simply put, poor inspiration pushes the diaphragm up, makes the lungs look wider and busier. Basically, the vessels get crowded. Okay? Poor inspiration can also exaggerate the heart size. And lastly, it can obscure lung bases and mimic pulmonary edema and infection. The answer to determining this is to count the ribs. Okay? You can choose to count the posterior or anterior ribs, but pick a side and count them. Most start with the posterior ribs as they're the easiest to find and follow. But for now, a brief review will show that you can see that the ribs attach obviously to the vertebral bodies of the thoracic spine and they go down. And so there's posterior ribs that start back here and wrap around to the anterior portion and of course connect to the cartilage. But you've got to be able to trace those in the image. And that does take a little bit of practice and effort. So let's now count. What you want to be able to see is that you have at least 8 to 10 posterior ribs in view in the lung fields, or at least 5 to 6 anterior ribs, okay? So let's count those on the actual chest x-ray. So you can see over here that we always typically start on the right side. Again, most people typically use the posterior ribs. And so if I were to follow the posterior ribs on this side, here's number 1, here's number 2, 3, 4, 5, 6, 7, 8, 9, and a portion of 10. So you'll see that we kind of fall into that standard range on the posterior ribs of the 8 to 10. That's that kind of normal bubble. Everybody's a little bit different, and obviously it's going to be influenced by some degree of their baseline lung capacity and if they have any underlying disease. If we follow the anterior ribs, remember we need at least 5 to 7 or 6 or somewhere in that window, okay? And so again, you have to be able to identify them and they're angled slightly different. Again, if you're not sure how to do that, please see my lecture on that. But here's 1, 2, 3, 4, 5, 6, and a portion of 7. Okay, so this is an appropriate number of posterior and anterior ribs for determining the inspiration. So this normal chest x-ray is normal in part because of that component. Okay, so if 8 to 10 posterior ribs is normal, then anything less than 8, okay, 7 or less, represents poor inspiration. If this is the case, then treat lung markings and heart size with some degree of caution, as there is a high risk of false congestion or what we consider also basilar infiltrates. What happens if we have more than 10 posterior ribs, right? So 11 or greater. That would suggest hyperinflation and air trapping as sometimes seen in COPD or asthma patients, if the technique that was done and the positioning are otherwise normal. I also advise a visual check in addition to rib counting to do a quick, full lung scan. So in doing a full lung scan and coverage, we want to consider a couple landmarks. The first thing is, can you see the apices at the top of the lungs? And that would be this area up here, okay? Next would be, can you also see the costophrenic angles at the bases? So remember that this is where the lungs meet up with the diaphragm and create this very nice, sharp, pointed area down here. Those are the costophrenic angles, right? So you want to be able to make sure that the image that you're looking at not only has the adequate inspiration, but encompasses those key points at the top as well as the bottom. Now, if the diaphragm sits very high and you can't see those bases, you need to think poor inspiration or there's some possible true reason for loss of volume, okay? You also want to look at the heart and the mediastinum. In poor inspiration, the heart can sometimes look larger and the mediastinum looks fuller, okay? Even when they're considered structurally normal, okay? Lung markings, and you can see some of those lung markings in these little kind of squiggly lines that go all the way out into the periphery if you zoom in a little bit closer, right? In poor inspiration, the crowds of pulmonary vessels occur especially at the bases, okay? And that makes the lung fields look more opacified. So you see this kind of fluffy looking opacities, and that can sometimes mimic vascular congestion or pulmonary edema, and sometimes even pneumonia if it's an isolated area, okay? Well, here's another clinical pearl for those wanting to be fully well-rounded on this subject. Portable AP chest radiographs or anterior posterior x-rays, okay? Those are the ones that we typically do in the hospital, ICU, emergency department, right? They're portable. They're prone to technical issues. What you see here is a patient laying in the bed, and of course the portable chest x-ray machine, or it's not just for chest x-ray, they use it for other parts of the body as well, but it's a portable x-ray machine, right? So you've got the x-ray tube at the top up here, right? And then they have plates that are in here that they put then behind the patient as they're laying in bed. But you can see that the positioning of this patient and their orientation to where the x-ray beams are coming from the anterior to the posterior on the detector, which is the plate behind them, may not be the same thing as if you take the patient into the actual radiology department where they're able to stand. Some patients are sick enough where they can't stand upright like this and expand their lungs and even potentially move their arms out of the way, which also helps to move the scapula at some level, okay? They cannot do this. And so typically what you see with anterior, posterior views, they're mostly portable in nature. Because if we're going to take someone into the actual radiology department, we're probably going to most likely do a posterior anterior, where the patient's anterior portion of the chest is facing the deflector, which gets the heart closer to the actual detector plate itself, okay? So the technique that is used is influenced in part by the patient's condition and their ability to be in a particular position, right? So if the patient is supine or semi-recumbent, like in this patient in bed here, right? They're unable to maybe take a full deep breath, or maybe they're intubated. They're unable to follow breathing instructions, okay? So I hope that made sense, and I hope that you found this information useful. Please consider subscribing to my channel on YouTube, and please give us a like so that we can continue to provide you with this type of free content. We also offer a free membership over at thisiswhy.health, where you can access things like downloads, images, get coupons, and discounts on test prep products. Ask me specific questions for future episodes. We also put together some various collections and playlists not normally found on YouTube. Lastly, if you want to see this topic that I discussed here about the adequate inspiration in the full context and a more comprehensive review on how to read a chest x-ray, please see the video that I did, the lecture on how to read a chest x-ray like a pro. I think it will definitely help you out and see how all the parts fit together. Until then, take care.